Hi there, happy Monday, and welcome to this week in review of all things that Aortic posted last week. Thanks for joining me here on AHTV, Aortic Hope's YouTube channel, live. And feel free to leave any comments or questions in the chat below, and we'll go ahead and get started here. And another thing to remember, because we like it when you like it, so click the like button, the subscribe button, the share button, and that little bell is a notification bell, and it'll give you notifications for any time AHTV goes live. All right, let's get started. Okay, every Monday we have a med student who will post an article pertaining to the aortic disease community. And this one today is, when do we replace an ascending aortic aneurysm? This touches a lot of people here. So this is a great article. This is contributed by our med student, Alvaro. Thank you so much for putting this in here, Alvaro, if you're listening. Okay, so anyway, today we're going to focus on a serious but critically very treatable cardiovascular condition with the ascending aortic aneurysm. These aneurysms represent a localized dilation or bulge in the wall of the aorta, specifically the section that arises from the left ventricle of the heart and travels upward, known as the ascending aorta. Because the aorta is the body's largest artery and carries oxygenated blood under high pressure to the rest of the circulatory system, a weakening or an expansion in this region poses a significant risk. So what is an ascending aortic aneurysm? The ascending aorta is the first part of the body's main artery, kind of the handle of the candy cane or the cane, the curved part. It's located right after the heart, and an aneurysm is when this section becomes enlarged or ballooned, making it weaker and more likely to tear or rupture. The primary concern with an ascending aortic aneurysm is the risk of catastrophic complications such as an aortic dissection, which is a tear in that inner layer of the aorta, or an aortic rupture, a complete burst of the aortic wall. Both events are medical emergencies with very high mortality rates. It's a life-threatening situation, but surgery can prevent it. So what are the symptoms of an ascending aortic aneurysm? Pretty much none. Most of them have no symptoms and are usually found by accident. Some other reason you go into the hospital, the ER, and you get a scan, that's when they find them. However, if symptoms do start to appear, they may include things such as shortness of breath, hoarseness, chest pain, upper back pain, coughing or wheezing, and difficulty swallowing. These symptoms often occur because the enlarged aorta presses on nearby structures. Since most ascending aortic aneurysms are silent, they're often discovered during imaging for other reasons. And if it's suspected, a healthcare provider may order a chest x-ray, a transthoracic echocardiogram, or a TTE. That uses sound waves to evaluate the aortic root and the ascending aorta and the heart valves. A chest CT scan, which it provides very highly detailed 3D images of the aorta. And with the contrast they sometimes will give you, it can detect even small aneurysms or dissections. MRI is MRI angiography. It's MRI focused on the chest and the aorta that shows blood flow, valve function, and heart performance without any radiation. It's the safer way to go. So when is surgery recommended? Surgeons use the size of the aneurysm to decide the right time to operate. 5.5 centimeters is universally agreed size where surgery is recommended for most people. 5.0 is recommended earlier in those people with patients with genetic conditions such as Marfan's or Loeys-Dietz, people with a family history of aortic dissection, and if there was a rapid growth, such as, half a centimeter in 1 year, greater than a half a centimeter in 1 year. And they want you, if you are having it sooner than later, like a smaller size, they suggest and prefer that you go to a high volume aortic center to have this surgery done. So think of it like a growing weak spot in a tire. The larger it gets, the higher the risk of it bursting. And if surgery is not needed yet, your provider may recommend beta blockers, ARBs, blood pressure medications that will bring that blood pressure down. ARBs are routinely given to people with Marfan syndrome. There are statins to control your cholesterol, follow-up imaging every 6 months, and then space it out if you become stable. Any lifestyle changes that are hindering, your health here, like smoking, eating poorly, lifting heavy weights, or, going too hard on the exercise spectrum. They want you to stop the smoking, eat a healthier diet, and avoid the heavy lifting, and do slow but low impact exercises. So there are some treatment options. There is the watch and wait, which I know some people here in this community are in that. It's used for smaller aneurysms, focusing on controlling risk factors and close monitoring. So they'll just watch and wait and get you scanned every so often, maybe 6 months, and determine if there's any growth or changes. There is also open surgical repair. The standard treatment for ascending aortic aneurysms, the surgeon will open the chest and remove the weakened portion of that aorta, replace it with a durable synthetic graft made of Dacron or something like that. And sometimes they may need to replace the aortic valve as well. This surgery does require cardiopulmonary bypass, which is the heart-lung machine, because the heart must be stopped safely during the repair. And the other way they can do it is an endovascular repair. It's a TEVAR, TEVAR, and it's performed through a small incision in the leg, delivering a stent graft to reinforce the aorta. Important to know, endovascular repair for the ascending aorta is still in early trials and not widely available. The anatomy near the heart is complex, so open surgery remains the gold standard. And then you have emergency surgery. It's required if the aneurysm ruptures or causes an acute aortic dissection. This surgery must be done immediately. But even with surgery, the risk of complications remain high. The final thoughts on this, says Alvaro, is replacing an ascending aortic aneurysm is a major operation, but when done at the right time, it prevents rupture, dissection, and it saves lives. Knowing the size thresholds and understanding why CPB is required helps demystify the process. That's all for today. He says, hope this was informative and maybe saved you from a risky ride. See you next week, says Alvaro. And he has several references for his article. So thank you so much for that. That was informative. And here's another one here. In Topic Tuesday, we have Pura has contributed about aortic root surgery. So let's just get right in that. Happy Tuesday with everyone. Happy Tuesday, everyone, he says. So with aortic root disease, patients and surgeons have several options for aortic root replacement. Today, he will be discussing these different techniques and the advantages and disadvantages of each. So what is special about the aortic root? It's a section of the aorta closest to the heart where the aortic valve sits. Unlike the ascending aorta, replacement of this section of the aorta requires management of the coronary arteries, which those are the ones that branch off of the root and must be reconnected after the aorta is replaced. Because the aortic valve is closely related to the root, it must also be managed. So in general, operations are separated into composite valve graft root replacements and valve sparing root procedures. So the Bentall procedure involves replacing the aortic root as well as the valve. And that is the compositive valve graft root replacement, Bentall procedure. And for this procedure, oh, this is a great image. It shows you the Dacron graft and where it sits when it is inserted. For this procedure, the aortic valve annulus, or the ring in which the aortic valve sits, is sized and the graft is selected with the valve that fits accordingly. Makes sense? So commonly, the fabric aortic graft and aortic valve prosthesis are prefabricated into a single unit that can be directly implanted. Patients may receive either a mechanical valve, which may last forever but requires lifelong anticoagulation, blood thinners, or a biologic valve, which does not require long-term anticoagulation, but it does degrade over time. The valve sparing root replacement usually encompasses two techniques, the Yaka procedure or root remodeling and the David procedure or root reimplantation. So both of these techniques involve preserving the patient's own aortic valve, which is which has the advantage of lasting longer than a biologic valve replacement without requiring the anticoagulation that would otherwise be needed for the mechanical valve. The Yaku procedure involves cutting out the aortic root sinuses where the aorta outpouches and sewing a graft into the valve to the graft in a crown-shaped manner. So here's a great diagram of that very procedure. So the David procedure involves sewing a graft around the base of the aortic root, which is right below the aortic valve annulus, and then sewing that valve itself in a three-dimensional configuration inside the graft to ensure a watertight seal and functioning valve. The additional suture line at the base of the root has the benefit of reinforcing the aortic valve annulus and preventing it from stretching over time. Here's some more great graphics here. So how do surgeons choose between them? Both surgeries have excellent outcomes, and the choice depends on the patient and the valve itself. Some factors your surgical team may consider is your condition of your aortic valve. If the valve is healthy, or it can be repaired, a valve sparing operation may be the option for you. Younger patients often benefit from mechanical valves over biologic valves to reduce the need for reoperation. Apparently, these biologic valves wear out in younger people than if you're older. And so, yeah, they do. They tend to push you in the direction of the mechanical valve if you're younger. Um, the surgeon's experience, not all surgeons perform valve sparing operations regularly. The Bentall may be recommended if a valve sparing operation is not suitable, or if a surgeon believes it will provide a more predictable long-term result. So thank you, Pura, for contributing this story on aortic root and valve surgeries. So Joshua, is anyone here saying hello to us? Oh, I see already. I took a peek. Hi, Velda. Hi, Rob. Hey, Terry. Thanks for being here with me and keeping me company. It's very lonely here until you guys showed up. So thanks for being here. And we're just going to keep moving right along. So we really are pushing our AHTV, our YouTube channel. There's so much programming on there. There's so much content on there, and there's something for everyone. And if you have not delved into our library of podcasts, live events, videos, all kinds of things on our YouTube channel, do so. And don't forget to notify so that you will get notified of any live events or any events that happen on our AHTV channel. So some of the things we have interviews, live Q&A sessions with medical professionals, therapists, pharmacologists, exercise physiologists. We have lots. We have so much, and they're really interesting. We have also our Survivor series and the Where Are They Now series, which is very popular. So all things aortic disease awareness, education, and it delivers hope to you because the more you're informed, the better you'll be. So check out go deep into our library on the AHTV channel and see what we have for you. All right, if you guys missed it last week, we had Dr. Siddharth Prakash come on with onto our Facebook page and answer all questions. So you can send your questions anonymously, or you can ask them live in chat, and they will be sent to Dr. Prakash to answer. So if you haven't had a chance, go back to our Facebook page and find this live event, and you will see all of his answers to your questions. And there's some really good questions in there. There were a lot of great questions asked in there. And if you missed it, check it out again. We have these frequently, and they're really great. And he's a great doctor that is so supportive of Aortic Hope. So thank you, Dr. Prakash. Here we go. My favorite Survivor Series Saturday. And in this case, this was a replay Saturday. So we replayed some of our more popular Survivor Series stories. And this is from Lydia, Alex and Lydia Lima, and they are together. He had the dissection, and she's his caregiver and wife. And it's a great story. You have got to check this out. It's a really, really, really good story. I really enjoyed it. So, and we have over 175, I think, survivor stories in our library on the AHTV channel. So go check it out. And if you haven't done so, go ahead and tell your story. Give us a little email to Joshua or myself and tell us that you are interested in which way you want to deliver your story. At the very least, you can just write it, and we will post your written story with a little photo of yourself or your family or whatever. We don't really like to have medical photos. So if you're all hooked up to tubes or, things showing, we don't really want that. We want a non-medical photo. The other way we do it, we can do a pre-recorded video of you telling your story, and then we'll air it on the AHTV channel. Or the best one is the live event, and that is where you go live with Joshua, our producer, telling your story with people in chat that could comment, support you, ask questions, and you can interact with them, after you tell your story. And it's a really great way to tell your story, and it's very cathartic for you, and it's really helpful to the community. So yeah, go ahead and send us an email if you want to tell your story. All right. So going on to Sunday, we have a resource page on our website, and there's lots of information, tons of resources. And one of them here is aortic disease terminology, and it's all thing aortic disease. It is a plethora of big words, lots of words, things that you may or may not know. But again, the more you're informed, the better off you'll be. So if you have a question about some terminology regarding your aortic disease, or your if you're a caregiver, you want to be more informed before you go to a medical appointment, check out this resource page on our website for the terminology, the glossary of terminology. Oh God. All right. Yeah, check that out. So we are wrapping it up. Oh gosh. Okay, so here is our events page on our website. And at the top, we have all the support groups. We have the caregivers only, which is for caregivers only. We have survivors and caregivers, and we have a Canadian group, right, Velda? We have a Canadian only support group for those guys up there. And we have the Grupo de Apoyo, which is a Spanish led group, support group, and our bereavement group, which meets every other month on the second Thursday at 7 p.m. Eastern. And by the way, all times on our event page are in Eastern time. All right, so what do we have here? We have me today. This evening, we do have a caregiver connection. If you are a caregiver and want to join, click on this link right here and it'll take you there. Tomorrow, the 18th, we have the aortic artist, Diane Bishop, is here live, and she will be doing, it says holiday decorations, but she clarified it was actually their ornaments. She calls them cos Cosmo ornaments. And what they are is they're glass or plastic ornaments. So they're clear. And then she decorates them. And there is a list of items in which if you want to paint along with her and create along with her, there's a list of items that she had mentioned in her post about what to bring to this. And it is at 7 p.m. Eastern time tomorrow, Tuesday. Sunday, we have Qigong with Kevin Songer. If you haven't done it, check it out. It's usually anywhere from 15 to 30 minutes, and it's Qigong, which is, I just explain it as it's similar to Tai Chi. So it's a low impact, slow exercise that you could do in the chair or standing up. So yeah, check that out. And then next week, Rob's going to take my place and then do the weekend review. And that's what we've done here. Yay, we finished. Um, well, let's just wrap it up. Let's just let people be on their way and start their week, and we look forward to seeing you next week. All right, take care. Oh, like and subscribe and share, do that whole thing, and notify anytime you want to see anything on AHTV Live. Thank you and have a great day.